Hello. I'd like to make a very rapid trip through the recently published National Hip Fracture Database report, published in the autumn of 2023, but predominantly focusing on what's happened during 2022, though the nature of the NHFD database and the website is so up to date that many of the figures that the report will lead you to relate to current performance and performance in 2023 rather than a year or so ago. Obviously, the impact of COVID remains a concern for people organising health services around the country, and the NHFD in its previous reports and in the paper that we based on the NHFD data mapped what happened with the COVID pandemic and the spikes in mortality paralleling the first two waves of the pandemic. Since the pandemic, things have been different. We're still seeing the NHFD still records COVID status for patients admitted with hip fracture. You're still seeing substantial numbers of patients having COVID during their time in hospital, but the benefits of the vaccination program and other improvements in healthcare mean that this isn't being reflected in mortality figures anymore. Indeed, from January 2024, we're going to stop recording COVID status in the data set because it really doesn't warrant the effort for data collection that it requires now that COVID is not having such an impact on services. However, if you look at the top of this graph, what you can see is that the post-COVID pandemic period is challenging. There has been a substantial increase in the total number of patients presenting over the course of last year. We went up from about 66,000 to about 72,000 patients presenting. And in December last year, there was an increase from the maximum we really ever see of 6,000 in December to 7,000 patients presenting in December last year. And you'll all remember the challenges that the NHFD, that hip fracture services and the health service and social services were under during December last year. The other thing that this graph demonstrates is that the impact of the increased burden, the residue of deconditioning, medical conditions, and the pressure on elective waiting lists is reflected in an increasing challenge of getting people to theatre quickly. So the COVID pandemic or its aftermath is still with us. In the course of 2023, the data subsequent to this graph does show a subtle improvement in the numbers presenting, and we wait to see how things progress over the year ahead. The annual report this year was focused on 5 areas. We've been asked to try and keep the report very concise, and it's a 10-page report as opposed to the National Joint Registry's 380-page report. So it's very focused. We've got 5 areas of recommendation that I'm going to take you through in this whistle-stop tour. Each of those areas are focused on how we try and improve our performance on the key performance indicators, and the website allows you to map what's happening over time for our key performance indicators, as I'll show you. First area of focus that we've recommended is that hospitals should go away and look at how they put together their clinical governance processes for hip fracture. We've always recommended monthly meetings, the teams to be meeting monthly or at least monthly, the clinical team to getting together to have a think about what's going on, how they should improve their care. We mapped the people who are attending such meetings in 2022, and you can see there's a fairly consistent pattern of people being there, surgeons, geriatrician, anaesthetists, nurses, therapists, and trauma and orthopaedic managers, the dominant attendees at those meetings. The other thing that we've recommended and changed that we've made in the way we structure things in the course of 2023 is move to produce a quarterly reporting cycle. So instead of just having an annual report, every quarter we will try and update our website. We'll have a quarterly online webinar which anybody can dial into to talk through issues in much the same way as I'm doing now. We're bringing out an NHFD quarterly journal, so an opportunity to review changes to the NHFD's design, its outputs, and papers such as some of those that I'm going to talk about now that have been published using NHFD data. and just to remind teams that they need to be updating their data so that it's available for analysis, particularly in the quarterly mortality analysis. So the first week of February, May, August and November, we have an NHFD update week. And that's a point in the year that we would suggest that teams go back to their data and have a look at their data. There's not a lot of point doing that on every month, going through your data in detail. It gets repetitive and you won't see change. You want to review your data on a quarterly basis and then use your other meetings to focus on introducing new improvement structures. But if you're doing a quarterly governance meeting, the 2022 report, last year's report, included a quarterly governance tool, which this is a simple guide really to people who are not necessarily aware of all the complexities of the NHFD database, and allows you to work your way through what's on there. So I give this to our registrar, I give it to a nurse or a therapist or one of your juniors, and ask them to take it away, and it'll guide them through a review of the data and show them how to get that data, how to understand what's going on, and make suggestions of quality improvement projects that might spin off from it. So that's a useful tool that we continue to recommend. The NHFD has produced an enormous amount of writing over the course, and this current report is just one of many. And the resources wrapped up in the reports, the facility surveys that we've done, some of the annual reports, and the database itself is a hugely rich picture. We're getting on towards 1 million patients' data having been processed. And there's a lot that can be done there that's beyond the role of an audit, which might just be looking at patterns in data. Really, an academic approach to that has long been necessary. And that's something that Celia Gregson's team at Bristol University, funded by Versus Arthritis, in the REDUCE study, have been doing over the course of the last few years. They've taken patient administrative data, reports, BOA inspections of individual hospitals, and a whole range of other resources, allied those to the NHFD data on individual patients and organisational data of the individual hospitals in the NHFD. And we've produced a number of papers from that, looking at how hospital organisation impacts on patients' recovery, patients' return to independence, and the costs of hip fracture. A number of other papers still to come, and that's an area that's well worth keeping an eye on. One of the things that was central to the design of the REDUCE study was their development of a toolkit to help hospitals improve their organisation, and this is very definitely on message with the first of our QI recommendations in our annual report. So looking at this on the Royal Osteoporosis Society website, there's a whole range of different things. There are checklists, there are design structures for how you could organise your MDT structures. There's a business case template and an economic calculator that allows you to work out the potential savings of different innovations in the way that your work is organised. If you dial back to the spring webinar of the NHFD, Celia Gregson recorded an explanation of all of this, and that's something that would be worth going to have a look at. One of the things that REDUCE showed was that hospitals that record follow-up data for their patients have better outcomes. So you can improve you can have a 10% reduction in mortality. We found in hospitals which got more than 80% of patients to theatre promptly, but you can also see a 10% lower mortality in hospitals which routinely use patient feedback information to inform their teams and their governance processes. And the template for NHFD data collection, 120 data collection, is available, including stuff that's necessary if you're going to look at whether patients return home, which is KPI 6, and whether patients are still on treatment, KPI 7. So using that, building follow-up back into your systems is really important, and as one of the key findings from the REDUCE work. The second quality improvement focus that we looked at is a drive from our new KPI 0, which requires that patients are admitted to an appropriate ward or a specialist ward where they're under the care of the MDT, the surgeons, the geriatricians, the nurses and therapists who'll be looking after them in the perioperative period, and that happens within 4 hours of them arriving in a hospital. they're also required to have had a nerve block, either in ED or on the ward, to achieve KPI 0. And that's really to put an emphasis on that most distressing period for patients when they first hit a hospital in pain and fear. The pattern of distribution of the performance for KPI 0 across all the hospitals of the UK is very distressing compared to some of our other key performance indicators. Most hospitals have very, very small, very poor performance across all of those, and that's almost looks as though this is an unachievable goal. However, you can see in the green hospitals on the right-hand side, some of them are delivering really quite impressive rates of early prompt admission. My hospital, the University Hospital of Wales, was in 2022 performing extremely poorly. We introduced a fast-track protocol off the back of what KPI 0 was telling us. So our line is the one bumping along 0 in 2021-22 there, below the national average for KPI 0. We introduced that, and that fast-track protocol, a Word version of that, is available to you if you want to try and copy it or build on it for your own hospital. And introducing that at the end of last year, we've seen a very dramatic improvement in what's happening, and we've got up to more than half of patients hitting our wards, getting to an appropriate ward within 4 hours. So this is difficult, but it is something that one can improve on, and it's the difference in the care that our patients and the patient experience that we've seen in our hospital, and in the focused nature of the work on that ward, has been an astonishing advance in the course of the last 6 months. So definitely an area to try and work at. Another thing that we did in the course of last year was some collaborative work with the College of Emergency Medicine and the Scottish Hip Fracture Audit and the Irish Hip Fracture Audit, looking at trying to question how patients are looked after when they're in the emergency department. The emergency departments have run sporadic audits over the years that really weren't very well integrated with what we've been doing, but we've improved on that, and there's this joint document that we produced, which includes drawing attention to the emergency department Big Six that the Scottish Hip Fracture Audit uses, requiring patients to have pain relief and early warning system, pressure assessment, blood tests, IV fluids, and delirium screening. And there's a tool here that we developed for ED staff, or indeed our own staff, to use as an audit to examine how well our patients are looked after in that very rapid assessments that they're getting during their time in ED. Really important. One thing it does highlight, though, is that we're not screening. The NHFD has not been requiring screening for delirium for patients presenting to the ED, and that's something that we are changing. A paper produced by Sam Hawley in the course of last year looked at the risk factors for the development of post-operative delirium, and looked at the impact of post-operative delirium on length of stay for patients, and their success in getting home again. And the importance of 4AT has become increasingly obvious over the time since we introduced post-operative 4AT assessment and delirium screening. The best practice tariff doesn't require that. The best practice tariff has been wedded to the use of the abbreviated mental score as a cognitive screen. And happily, we've now got agreement from the National Clinical Directors to change that. So while you're familiar with adding the post-operative 4AT to get BPT and as part of KPI 5 for the NHFD, from January in 2024, the 4AT is what we would prefer you to be using for pre-operative screening. So when patients first present, they should be having a 4AT, and then again after surgery. And from April 2024, the best practice tariff will be contingent on your having done that rather than having done an AMT score. So a real change there, and the hip fracture care in the UK really driving forward the assessment and understanding and our research into the management of delirium. Another innovation in terms of the early care of patients in the NHFD is that we've added a new line to the length of stay run chart that you're all familiar with. And this new red line is designed to capture the time that patients spend either still in the emergency department, or if they're not sent to the appropriate ward, if they're not sent to an orthopaedic, orthogeriatric ward promptly, the time that they're spending in outlier beds where they may not get the care that they would otherwise want. That's a topic addressed within the REDUCE study as well. But for some hospitals, outlier time is a real challenge, and certainly in my hospital, the fast-tracking of patients to the right place has been reflected in this red line, so it's something that you might like to use. The surgical care of patients having hip fracture has been fairly stable over time in terms of essentially 98% of patients will have surgery for hip fracture. During COVID, there was an initial spike of patients not being able to get to theatre, but that side of things has settled down. But the third focus of the new report is on the changes in surgical care, and certainly the attitudes to the use of total hip replacement are one of those areas that are reviewed in the report. I'm not going to go into this third area in any great detail, but I should point out that for individual hospitals, there's been quite a big change in how many total hip replacements are put into patients who would have met the original NICE eligibility criteria, and that the yellow line in the surgery chart has mapped the change following the health trial, which questioned some of the advantages of total hip replacement in the shortish 2-year outcome of hip fracture. The COVID pandemic had a subtle additional effect in reducing total hip replacement numbers, and NICE published at the beginning of 2023 further guidance, and we haven't yet seen the impact of that on performance figures. We've not changed the specifications behind this line, even though the NICE criteria for surgery have changed quite significantly. We've kept the criteria behind the line the same, so that we can use it to monitor how people respond to the new NICE guidance. This has never been a line that runs very high across the page, but it gives us a real sense of surgical attitudes to NICE guidance. The fourth area of focus within the annual report is on our ability to get patients out of bed by the day after surgery. And we know that the proportion of patients who are promptly out of bed on the day of or the day following their operation varies enormously across the country, and some hospitals really struggling to achieve this for anybody. Most hospitals achieving this for the majority of patients, and KPI 4 running at about 80% of patients able to get up. But there's enormous variation in that around the country, and one of the reasons behind that is that there's enormous variation in the proportion of patients who are identifiably delirious post-op, or using KPI 5 who are screened and demonstrated to be free of delirium. So this variation in the physical and the mental state of patients on day 1 post-op is something that KPI 4 and 5 challenge. And the report questions whether hospitals are really looking at the reasons why patients are failing to get up on their day 1 post-op. You can export your data, you can look at this. It's a great topic for a short quality improvement project with therapists. But this isn't really about therapists, and pretty much BPT certainly, and in most hospitals, patients will have a physiotherapist with them on day 1 post-op, but that physiotherapist is often unable to get people up because of other difficulties, the poor quality of management of blood pressure, of pain, the onset of delirium particularly having an effect there. So one of the recommendations in the report is that the teams should be looking at how fit patients are when they leave recovery, making sure that we use the expertise of the anaesthetist in understanding their blood pressure and understanding blood loss in theatre to make more formal recommendations of how patients should be managed in terms of their fluid management, blood pressure management, pain management in the night after theatre, the ERAS type work to try and improve rapid recovery. And that's certainly an area that's worth exploring. one of my YouTube videos from my YouTube channel is a very simplistic summary of the perioperative management of patients, and the complex frailty of our patients does make this seem very challenging for junior doctors. But this short video is designed to encourage people to think about the key aspects of perioperative care, the management of hemorrhage, immobility and pain, which are fundamental to our success in getting people out. So I use this as a resource for induction for juniors and for students, and I would suggest that it's worth playing with. But the other thing is just thinking about the process of looking after people on the night after theatre. They're often coming from theatre to a ward where night staff may not have the same levels of expertise, and there may not be junior doctors available to look after them. So giving clarity to junior doctors and staff on the ward as to what the priority should be if they're going to make sure that people are able to get up post-op. And the whole purpose of surgery and anaesthesia is to get people up. It's not to get them through the operation. It's not to achieve a nice looking x-ray. It's to make sure that people are in a position to be out of bed having lunch on the day after theatre. So this is definitely one of the areas that everybody needs to be focusing on. And then the final quality improvement focus that we talk about in the report is this enormous variation in the quality of secondary prevention that's offered to patients. You can see in this chart that essentially half of this page is blank. So half the patients in the country have nothing given to them as bone protection to try and reduce their risk of having future fractures. A quarter of them will go on and have a fracture. We can reduce that by perhaps a third with appropriate treatment. But most people the majority of people get nothing, or they get a lendronate but with no follow-up to make sure that they're actually able to take that and that's suiting them. Most people who come in on a lendronate go home on a lendronate. There's no attempt made to recognise that these are people at imminent risk of fracture, and that a lendronate is pretty much an ineffective approach to secondary prevention. Whereas we know that zoledronate, we've got an RCT showing the benefits of zoledronate. There are more potent treatments out there, but zoledronate's a very easily given therapy. There have been lots of uncertainties over the use of zoledronate in hospitals, quoting all sorts of excuses for not giving zoledronate to their patients. But as you can see from here, some hospitals are now delivering 2/3 zoledronate or other injectable therapies to 2/3 of their patients. And in a piece of work with collaboration between some of those hospitals, we've written this paper which came out in Age and Aging in the same month as the annual report. And it's a description of very simple protocol to allow you to get patients loaded with vitamin D, to give zoledronate to patients unless they've got a creatinine clearance of less than 30, and to make appropriate decisions about future zoledronate therapy or follow-up for those individuals. And our expectation is that if all the hospitals in the country emulated the practice in the best, we could see 25,000 more patients receiving bone protection in the form of injectable therapies in the course of the next year or so. So definitely a paper to go and read. So those are the 5 quality improvement targets. There are a couple of other new topics that are worth mentioning before I finish. Inequalities in healthcare are something that we've tried to look at. We don't really have enough data within the NHFD to try and tackle the inequalities questions at this stage. We can see that the practice isn't affected by patients' age. So however old the patients are, they seem to have the same access to a consultant, surgeon and anaesthetist in theatre. There is a tendency for older patients to be more likely to see a geriatrician, and that does raise the question of whether we should be looking at equalities or inequities in healthcare, because people who need more care, so the older, frailer patients, will have greater need for instance, a consultant geriatrician to look after them. But these are really challenging questions, and there's quite a lot of work that will need to be done to build in understanding of patients' socioeconomic status, their ethnicity, into these sort of analyses. We can look at the process of care in the way that I've described here, But looking at the outcome of hip fracture care is a much more complicated project, and there are a range of questions that we need to think about. We know that men do less well than women, but we don't know whether that's because they're men or because men tend to be older and in poorer health. These sort of complex questions would require quite sophisticated analyses, and that's something that we're looking forward to delivering in the course of the next year or two. And finally, the other area that the report always talks about is monitoring mortality. And I've talked in previous webinars about the way in which we have this run chart that allows us to be reporting your mortality, your 30-day mortality figures for individual hospitals on a quarterly basis. So the data for patients who died only perhaps 6 months ago is now available in a case mix adjusted model. Refer you back to my previous talks about that. That data is very much available, and that process is working in contact with hospitals who are outliers for mortality, perhaps a year earlier than we would previously have been, and nursing hospitals through an understanding of what's going on and supporting them in making improvements. The new resource that's available in this year's report is this plot which allows individual hospitals to look at how they compare with their peers, to benchmark themselves against other hospitals in the country. So this 30-day survival chart is on the KPI page of the NHFD website. And actually this is quite a nice way of drawing your hospital's position to the attention of your team, to your managers, if you're concerned that you really want to be focusing on mortality as opposed to all of the other key performance indicators. So that's another thing to go and look forward to. I will add this webinar to the resource of other YouTube videos that are available on my Cardiff University webpage, but it's something that we will be talking through in a number of our other webinars over the course of the year, and I'd refer you back to the webinar resource on the NHFD website that allows you to look at some of the previous webinars I've mentioned.